And our next panel is going to really take power to the people, because it's going to look at people and civil society at the core, from slogans to action. I'm delighted to pass the moderation baton over to Claudia Marinetti, who is the treasurer of EPHA and who's going to be the moderator of this session. Claudia.
Thank you very much, and thanks, Tamsin, and all the speakers for a very interesting session. What we will do now, we heard from experts in the field of public health, people that have really deep knowledge on policies and practices, and now we are going to address the expertise of those for whom public health is, of people. I would like to start with inviting here our speakers to sit. So Natasha Azzopard-Muscat, who's Director of Country Health Policies and Systems at WHO Europe. Maya Matthews, Acting Director for Digital EU for Health, Health Systems Modernization at DG Santé for the European Commission. Denis Onyango, Programs Director at Africa Advocacy Foundation and also an EPHA board member. Nicola Bedlington, Special Advisor to European Patient Forum. And Rebecca Barlow-Noone, Communication Officer at EPHA. Thanks. So in the past few years, we started hearing a little bit more about co-production. But we've also seen that meaningful involvement of people with lived experience remains limited. And very often this involvement is limited to consultations that become sometimes just a tick of the box type of exercise. And that also involves those that are more easy to reach. As we know that we need more than ever trust in public health and also efficient policies and practices, let's look into what we can do to improve and to really embrace a true co-production approach. We have 2 rounds of questions, and I've asked our speakers to limit themselves to 3 minutes because we don't have a lot of time, so that everybody can have their contribution. So in the first round, we know that very often the discussions or presentations on these topics are just a shopping list of what past consultations have been, or what opportunities have been. But we should try really to examine what we all institutions and civil society have done to improve dialogue and to make sure that the expertise from the civil society is really taken into account. So Natasha, what has the WHO done recently to facilitate civil society input and improve engagement? And is there anything planned to build on this?
Thank you very much, Claudia. And just to say, it's a pleasure for me to be here, of course, representing WHO Europe, but I feel that I'm back in my own family as past president of the European Public Health Association, and a great previous panel, Tamsin, hearing everyone. I was just a bit alarmed because when I heard Martin McKee saying, and I've mentored a lot of the young people, I said, that's me. But actually, I'm not so young any longer. And looking back, having been a member state, having been part of civil society, academia, and now WHO, I think has allowed me to really get a sense of the different players and what they can do. But when Dr. Hans Kluge, who you heard earlier on screen, and he's really committed to civil society, the fact that I am here today for a day, I think is testimony also to his commitment. When we launched the European Programme of Work, we put partnership at the heart. And I think we can say safely, less than 4 years later, 3 years later, concretely with examples, what we have done. So let me just list 3 or 4 examples. The first one, we built up the Pan-European Mental Health Coalition. Claudia, you are part of that. We now have almost 300 members, 60 of them being civil society organizations. And we are also now piloting new ways of really involving people with lived experience, particularly young people with lived experience. And this is not easy, huh? It's a learning exercise for everyone. It's challenging. There are ups and downs, but we move forward because we know that this is the only way. Secondly, we launched the Novel Medicines platform. And again, over here, we have already, I think, 23 civil society organizations that have joined the Novel Medicines platform. Why? Because it's not enough just to have the funders, the member states, and the industry. We also need civil society there in between. And we are also launching the Digital Health Partnership. I was really glad to hear Josephine come down on the optimistic side. Last week, we had this large event in Porto, really questioning the heart of digital health. And what is very clear is that we have inequities, that digital literacy is not working for all, that it's not yet working for the professionals. How can we change this? If we put patients and health professionals at the heart. And this is what we are trying to do. And Martin just briefly mentioned the Tallinn Health Systems event. We are putting patients and workers as the drivers with technology to bring about the much needed change. The last initiative that I'll mention is the Youth Initiative, again, that we have set up as WHO Regional Office for Europe. We have issued strong recommendations also that a young person is forming part of the delegations to the regional committee, because we want to make sure that young people are very much involved in charting the way forward. We know that they do not always feel that they are part of the society. We know there is anger. They feel let down in a way when we start seeing, you know, all these crises. And the only way is to really allow them to be part of and to steer. Why do we do this? We do this because we believe in civil society, but we do this also because the challenges are so large that no single organization can go it alone. Thank you.
Thank you very much. And Maya, what efforts has this commission made to improve civil society possibility to give input and meaningfully consider it or include it in the work of the commission?
Thank you very much. First of all, I just must say I was very inspired by the last session. I'm very happy to see so many colleagues, friends, and I do want to take a moment to also say that for me, it's very personal and professional. Personal because to see Michael Marmot here today, you don't know me, but I can tell you that your work inspired me to start working in public health. So thank you very much. So health inequalities has always been my passion, and working with Caroline all those years in EuroHealthNet, I'm so proud of you, Caroline, and how you've kept health inequalities top of the agenda. I think more than ever, we need to reboost this because what we're seeing post-pandemic is very alarming. In many occasions, I've mentioned the fact that life expectancy now has seen something that we never thought was that we were going to see in this continent. It actually went down in most countries. We are seeing a rebound, but that's a very general figure. And we need to really pay attention to what's happening and how much the pandemic has exacerbated those who are already left behind. From a professional point of view, I also want to commend all of the very strong leaders of EPHA, because we mentioned very many male giants, but there are very many female giants here. And I'm looking at Tamsin, at Monica, who's here, Milka, who's now taken the reins, Janon, who I think is coming. So as I said, for me, like Natasha, it's a little bit like coming back to a family. But now let's discuss the question. I think the Commission has made a lot of progress in engaging civil society, but I think we can't expect a one-stop shop. We do have a formal framework, which is the Better Regulation framework, which ensures that at a very early stage in policy proposals, there is an opportunity for stakeholders to respond. And I want to make 2 points here. One is the language, so you can put your comments in any of the EU languages, but also it's transparency, because everyone's comments are there for everyone to see. So I think that one of the areas where the Commission has made a lot of progress is this reaching out beyond formal organizations. So you have, individual citizens replying. From the health side, we have the health policy platform. I think that has been raised in visibility, partly due to the pandemic, when it was not possible to meet. But as everyone knows, and I think all of us here work in the health community, we are all exhausted because all of a sudden the spotlight was on us. We were asked questions we couldn't answer. We were expected to deliver on things that we'd never delivered on before. But I think everyone stepped up to the plate. So Martin gave a very sobering view. I would like to give the view, especially to the young people out there who might not be as exhausted as we all are, but you can see that you need to grab these opportunities, that the unimaginable becomes reality. Who would have thought that together in Europe we would purchase vaccines that didn't even exist before? I mean, I think sometimes we're always, and this is something I can tell you from the Commission Health Department and yourselves as well, I think we're very critical of ourselves. We put ourselves in a very high standard, but once in a while, let's just look around and celebrate a little bit what we've achieved. Okay, I saw the what you put on the Slido, and I saw that everyone is putting, you know, a lot of negative things. But for one moment, before the next commission comes in, and that I'll speak about next time, let's actually kind of just see what we've done in this space. We've actually created a brand now called European Health Union. That didn't exist before. Let's capitalize on that. Now people know that there's something called the European Health Union, which means that the EU has a strong place in health. But I see I'm going too long, so I'll stop here.
Thank you very much. Denis, you have extensive expertise of ensuring that those living with HIV, hepatitis, mental health problems, TB, and other conditions are heard by policymakers. Have you seen recent developments which encourage you or not?
First of all, thank you. It's a privilege to be here, and hello, everyone. As you know, significant barriers remain, certainly in terms of healthcare access, particularly for key populations. So I do work with migrants, but I'm also involved in a network called the NLO, which is Nobody Left Outside Initiative, that is working with some of Europe's most underserved populations, including LGBTI people, men who have sex with men, migrants, sex workers, prison populations, homeless people. And we see definitely that healthcare systems sometimes are not really including everyone. For example, in terms of HIV, where I work, significant gaps remain in prevention, in testing, prevention, testing, treatment, and definitely in terms of people who are living good quality of life. And so we obviously continue to work, and I'm quite happy to say that HIV is one area where civil society organizations have worked very effectively with policymakers and key institutions. And I'm encouraged by the new regional action plan, the WHO regional action plan on HIV, which is basically looking at trying to promote a partnership-based approach of work where civil society organizations, public health institutions, and professionals are going to be involved in trying to address the barriers that exist. I like the idea that the EU, the upcoming EU Spanish EU presidency has prioritized eliminating all forms of stigma, HIV-related stigma. So putting that political action into use. I think that's really interesting. I'm also encouraged by the ECDC approach to try to improve the data gaps, the gaps that exist in data collection, because you cannot make good policies without, data. So there's a meeting actually happening in Seville where the network, WHO and ECDC, are looking at how they can support countries to collect more comprehensive data, disaggregated, which can help inform policy. So I think that these are really significant, for me, significant achievements. And I always like to appreciate the opportunities we've had as civil society organizations working on HIV across the board to be able to engage directly with clinicians, with public health experts, with commissioners and funders of services to be able to highlight what we feel are the needs. So I know that there are, of course, concerns around people's ability to access healthcare. We still know that in Europe, a lot of people are excluded from accessing healthcare based probably on their immigration status or their social status. And we want to work to be able to eliminate that. I think on the negative side, it was quite unfortunate for the Commission to kind of close the Civil Society Forum in its previous form, because I think that was a very, very good tool. I know the EU health policy platform is there, but I feel that the Civil Society Forum was actually a very good way of engagement, and I would encourage, the Commission to be able to consider opening that, so that we could have much more, inclusive and very transparent discussions with you on issues that we see in the system.
Thank you very much. And Nicola, you have a lot of experience of civil society beyond the health space. Are there examples, from other policy areas which health policymakers could learn from and improve the role of civil society and their impact on policymaking?
Thank you, Claudia. Can you hear me? Good, fantastic. And first of all, I must also give my great congratulations and thanks for the role of the European Public Health Alliance over the last 30 years. It's been phenomenal, and I'm really proud to be here with all of you. So thank you for that. My main experience beyond the European Patients Forum was the establishment of the European Disability Forum back in 1996. And I do think there are also lessons that we can learn from that era. The European Disability Forum grew out of a European Commission programme called Helios, which was fighting for the human rights of disabled people. And when that programme ended, initially the Commission was very keen to actually, DG5 at the time, it was numbers back then, the Commission wanted to set up an internal disability advisory committee rather than an independent organisation. And that took a lot of careful discussion, negotiation, constructive thought processes to get to the point where it was recognised that a bona fide civil society organisation was the right way to go. And then there was the whole discussion about funding, because there wasn't a funding base. So we had to set up a specific campaign called Fair Deal, give disabled people in Europe a fair deal to get the funding base for the Disability Forum, but also for our members, for organisations representing people with intellectual disabilities, for people with profound deafness, visual impairment, and so on and so forth. So that in itself was a real battle, but it was a really, really exciting era beyond that, because it was the time when a number of social organisations were coming together to set up the social platform. And we fought successfully for the reinstatement of funding for social NGOs, giving at the time the Commission, with a little bit of a tongue in cheek, the red flag, the red card. We had a big conference in Heysel, and obviously it was the time when the World Cup was on, and all of us were there with our red cards saying, this is not on, we need to have institutional funding to actually function. Another major success was the inclusion of the then Article 13 in the Treaty of Amsterdam, which outlawed discrimination on the grounds of sex, age, race, ethnic origin, religion, disability and sexual orientation. And this provided a crucial legal base for very progressive legislation, but also soft policy in that space. And all of the organisations concerned ran our own campaigns. EDF ran a campaign called Invisible Citizens, because until that point, disability didn't feature at all in the treaty. And we also backed that up with an academic publication from Maastricht, so the evidence was also there. But all of the social NGOs involved ran their own campaigns, but we coordinated those really smartly and worked in solidarity, a word that's been used already much this morning, in solidarity, in sync with all the EU institutions and presidencies. So we had a lot of allies. We had a lot of allies within the community, but we had a lot of allies within the institutions, a lot of strong leadership. So I think there are some parallels with some of the challenges and opportunities we have in the health community today. And it's fabulous to see the leadership, to see the courage and also the cooperation in our community, spearheaded, of course, by EPHA, the European Patients Forum, and many others. I think we're in a very exciting time and much more can be achieved, but I agree with you, Maya, there's been a lot that we can be proud of.
Thank you very much. And Rebecca, so this session is very much about nothing about us without us. So yours is a crucial voice from an expert by experience perspective. And so from both your own lived experience and your work, what have you found as the biggest obstacles that need to be removed to truly and meaningfully involve patients in policies and practices that affect them?
Yeah, so is this working? Yeah. Yeah, okay. So I'm kind of taking quite a practical approach to this. So as a person, I live with type 1 diabetes. I've lived with it for 8 years. And throughout my experience working in patient representation, lived experience, you see, it's an incredible thing, and it's something that many organizations are just starting to dip their toes into. And I'm really encouraged to see that. But there are many things that you really need to consider when you're involving lived experience. So, like, for example, type 1 diabetes and many other NCDs have an enormous impact on your life. Like, it permeates everything. And if that's the case, then we need to get representation from a broad section of society, because if your condition is impacting your life to such a degree, then if you're experiencing fuel poverty, if you're experiencing food poverty, if you are an asylum seeker, if you are experiencing homelessness, these have enormous impacts on your ability to self-manage and your ability to actually achieve patient outcomes that are set by your health system. But what I've seen in patient engagement is that by its nature, you need time. And as someone who's volunteered in many organizations for type 1 diabetes, you do need a significant amount of resources yourself to participate. And this isn't often considered. And I think there's also great efforts to address this. There's many organizations who do work towards improving engagement by supporting people with transport costs and things like that. But there's still a long way to go to actually see a broad representation of society and lived experience. And then once you're actually involved, there's also many considerations as well. So as someone involved in a lived experience panel, you need to really consider all the factors that you bring with you. As I've just said, you can have an NCD, but also experience homelessness, domestic abuse. These things are they need to be considered from the start. So if you're involved in telling your story, things that, putting yourself in quite a vulnerable position to influence policies, that needs to be done with such an amount of care to make sure that that doesn't also involve re-traumatizing the people who are involved. And thirdly, there's a lot of talk about involvement through the entire policy process to make sure that any kind of involvement isn't simply tokenistic. I've been involved in numerous projects where I'm involved from start to end, but then also when it's maybe just reflecting on the results of a policy research. And then that kind of tokenistic experience, it does make you feel disempowered because you're not involved from the start. You're not involved in defining what a policy needs. You're not involved in defining what you as a patient community want to see. And if you don't have that very early engagement and late engagement, then we're not going to see policies that really impact people, people who are going to be affected by the policy themselves. So there really needs to be early consideration of how you involve people and make sure that that involvement is recognized and seen on the same par as other consultants or other people, because lived experience is just as important as any other experience that we bring to the stage.
Of course. Thank you very much. And this closes the first round. I think that there are definitely promising things happening. I think that we can learn from the past, and that working together as allies is a way forward. And there's still quite a lot to do, also in terms of changing the culture, because this is one of the reasons why it's so difficult also to properly engage with people with lived experiences, that somehow people are unable to sit at the table and consider the expertise of everybody as valuable. And while if we want to have effective policies and practices, you do need that. You do need to listen. You do need to enable also people to participate. Before we pass to the second and last round of questions, there is another question on Slido, which is how can we ensure participation of people and civil society in health policy? So while you are giving your ideas, I will go ahead. So I will go back to Natasha. We want basically to think what extra is needed to further improve the situation and how we can have collective efforts really to better involve civil society voices in policy making really from the beginning to the end, and also maybe giving the feedback on how the input has been taken on board. So, Natasha, member states, civil society organizations, observers all make demands on WHO. What would you think they all could do or do better to make your task of including CSOs easier and more effective?
Thank you very much, Claudia. So I think actually as WHO, we are able to include CSOs. And as I answered in my earlier round, it's happening. I think the next step, however, is to work with member states across the region to ensure that at that level, at the local level, at the regional level, at the national level, civil society is being involved. And the consultation that we had yesterday, which was a member state consultation on how can we improve and institutionalize social participation, I can give you really just sort of just out of the oven the main points that were discussed during this meeting yesterday. So as WHO, we have two key asks to our member states. And what is nice is that it's a handful of member states themselves that have recognized that more needs to be done and that are working with WHO, even at the level of headquarters. We want to try and have a resolution coming forward. But the two key asks to member states are, first and foremost, make sure that there is the legal basis. Commit yourself and make sure that there is a strong legal basis for the involvement of civil society in decision-making. Why? Because governments come and go. Actors come and go. And unless it's enshrined in legislation, we remain open to the risk of having a government that is more or less friendly or empathic to civil society. Secondly, and this is a tall order, but it's really important. The first panel mentioned the importance of transparency, and I will come back to that. So sometimes civil society, when they are saying things that may not be pleasing either to governments or to lobby groups, are immediately targeted in terms of their support, their funding base, etc. Now, one of the ways to avoid this is by having mechanisms for sustainable funding for civil society. Now, of course, sometimes this is hard because you are funding those very organizations and asking them to hold you to account. And let's face it, it's not easy for a member state, for a government, to be putting money into building the capacity, the voice, the strength of civil society, asking them then to hold you to account. But this is necessary. So this is our second ask for member states. And of course, closely related to that is the capacity building. Particularly, we see that across our WHO European region of 53 countries, the capacities vary enormously. And what we tend to see also is when we come even to consult with civil society, we have patchy representation across the region. We tend to see an over-dominance of native English speakers. We tend to see more people from the north and the west of our region being active rather than from the south and the east. So we need also to work very much to build the capacities. We also, however, have asks to civil society. And one of the first tasks is be true to the mandate and be honest, impartial, and hold us to account, because this is what we are asking you to do. We're not just asking you to come there to fill the seat on the panel so that we can tick the box that we have civil society, but tell us what we are doing good, because we need encouragement too, and tell us where we can do better. Secondly, be inclusive. Make sure that you work hard to ensure, particularly for the European-based civil society organizations, that you truly involve everyone, men and women, people from different areas, people from across the region, because you need to help us also to reach out and to build the bridge in this regard. And then monitor, help us also with the data and help us to show the impact, because several times people question, what is the impact of funding civil society? Already they are holding governments and powerful industry to account. So you're already starting off with all of that. And then secondly, help us to find ways in which we can measure and demonstrate the impact. So that comes out of yesterday's consultation, and I'm very happy to already have the opportunity to share them with you here today.
Thank you very much, and it's great indeed that you could do that. Maya, what would you say are the major obstacles to properly include contributions from civil society into the work of the Commission, and how do you think that these obstacles could be overcome?
Well, first of all, I want to thank you, Natasha, because you said everything I was going to say. So I'll say something completely different. No, I mean, yes, all of everything you said is absolutely true also for the EU. I wanted to maybe just add maybe a little bit of nuance, that it's also timing is very important. And for example, tomorrow is the President von der Leyen's State of the EU speech. So I invite you all to listen to it, because that will be the kind of blueprint of actions in this year. And this year is a very important year because it's the last year of the Commission. So we still have a lot to achieve, and we hope to achieve it. I think you all know the legislative files under the health DG that we're aiming to end, including the digital European health data space, which I hope will address some of the issues that Josephine mentioned. The second issue I wanted to also mention, and here I should also say, if Michael Marmot inspired me to study public health, then Martin McKee inspired me to work on European health, because I love complexity. And boy, was I not disappointed. But here as well, Europe, it's so complicated. And very much what Natasha said is that we need to be inclusive. So here I would just like to make a plea that we need to find a balance between getting the very good European level organizations to work closely with them, but we also need to reach out on the ground for many of the reasons that Martin mentioned, that we know that we've seen how there's been a backlash against many health policies. As I say many times, who would have imagined that something as simple as a mask was going to become such a controversial issue? So here, this would be my ask to you, is that let's work together to see how we can ensure that civil society is truly represented at all the different levels. I would also say that we need to focus our message, look at what's been achieved, and identify now the next steps. So here I invite all of you, EPHA, but also all of the members of EPHA, to share with the Commission your proposals, your ideas for the next mandate. So this time right now is crucial, because this will then set out the next mandate of the Commission. We don't know who it's going to be. For your information as well, you know, we can't, as I said, I mean, I'm a positive person. For those of you who know me, I'm an optimist, but I do think that health is definitely on the radar. But we have a lot of competing issues. We don't even know with the geopolitics these days what's going to happen next. So my plea to you is to keep the momentum going, keep asking for, you know, health to be on the agenda, but be realistic and also be inspiring and creative. And as Natasha said, give us the data. because that helps us to also make our case internally. But really my invitation here is that I explained in my first bit, there are many different ways to engage, but this year particularly, I think it's very important that we work closely and hear from you where are the areas where you think the EU can have an added value in the years to come.
Thank you very much. And I think the people in the room have listened and will be active. Denis, what can civil society do better? And are we doing enough to recognize some of the constraints that institutions such as the Commission have? And we can either work within these constraints or even campaign to change them from the outside?
Hello. Yeah, so I think Maya and Natasha really have summarized some very key points around inclusion and involvement. But I also just want to emphasize, I mean, of course, there are opportunities to be able to engage more with the Commission and to be able to highlight some of the issues we see at the grassroots. And, you know, we always talk about numbers and statistics, but behind those numbers, there is a person, you know, if we say 2.6 million people are living with HIV in Europe, for example, or 14 million people living with hepatitis B, or 25 million people living with STIs, these are individuals that for some reason were failed by the healthcare system. And I think that what we need to do as community organizations or civil society is to be more bold about our expertise, to be, because most of the times we assume that people in key institutions or policymakers know it, but actually most of them really need that expertise that we offer to be able to provide that insight. So I think that we need to be more bold as civil society organizations, because we support healthcare systems. I mean, without civil society, there will be a breakdown because of the burden we kind of carry. And we play a huge role. So I think that we should be very proud of what we do as civil society organizations. We should challenge ourselves to be more inclusive, you know, as organizations, as a team, try and get because there's no point me sitting here and talking about experiences of a woman who's experiencing violence, for example, that I've never been through. So I think it's only by bringing these communities to the fore is when we can actually make meaningful change. I do believe that channels of communication and engagement should, you know, be maintained. I think it should not just be consultations, but, you know, we should go through to implementations and monitoring and seeing how the results can be shared, because most of the time there's a tendency to just, you know, consult and see that there's been some involvement, but in terms of really seeing whether those policies are making a difference, you know, it's not really that inclusive. So I think that should also be done. I think that's what I could probably share. Thank you.
Thank you very much. Nicola, what can civil society do more to ensure that the voices of those with lived experience are truly part of the discourse, including of civil society organizations, rather than just the institution's response?
Sure. I mean, I think Rebecca expanded on that very nicely. The European Patients Forum has just published a manifesto on meaningful involvement, again, describing how important it is for it to be institutionalized, to have a full circle approach, to look at diversity, equity, and inclusion issues as well. Clearly, there is an intrinsic added value in involving and engaging people with lived experience, and their expertise and experiential knowledge really do contribute to much more effective and cost-effective policies, but also better outcomes, focusing on their needs, on their goals, that impact not only on individuals, but also on society at large. But this can't be done with fresh air. It requires appropriate resources for representative organizations to function and to play their legitimate role. It requires training and capacity building to enable people with lived experience to meet policymakers and other stakeholders really at eye level. And I know that EPHA and EPF and a lot of other organizations in our space, also at national level, are investing heavily in that, also with young people, and that must continue. We need an enabling policy environment. And of course, an excellent example is the European Medicines Agency, with the sterling efforts that they've put in over many years to make sure that patient and consumer involvement is embedded into the entire organisation, with the Patient and Consumer Working Party, scientific advisory committees, the pharmacovigilance assessment, risk assessment committee, and indeed a voting right at the management board. So I think that is a very good example. It also requires, from a legal perspective, the term is reasonable accommodation. What does this mean? It means interpretation, also sign language interpretation. It means proper breaks in discussions, in consultations, because fatigue is a major issue for people living with a chronic condition or with a disability. It requires a reasonable time frame for people to respond thoughtfully, accessible, non-alienating language, a feedback loop, what has been integrated, what has been rejected, and why. And also, and it's been alluded to, but it's really important that people with lived experience are also engaged and involved early enough, but also end of pipe when it comes to review, evaluation, and thinking about moving forward constructively on policy. So there's a lot that can be done. None of it is rocket science. It is workable, but it needs a lot of collaborative thinking. It needs resources and it needs community to make it happen in real terms. I had lots of other things to say, but I'll stop. You'll be relieved to hear.
Okay. Well, you've all been very good. Rebecca, so does this dialogue have any meaning to those that are living with a serious condition? And how does a lived experience background relate to this discourse, and what should change to improve it?
Right, so I think I'm going to echo a lot of what you've just said. I think one of the things that hasn't been mentioned so far actually is how lived experience networks and involvement can actually result in peer support as well. So there are mutual benefits to lived experience engagement. Like, I've been involved with the International Diabetes Federation Europe, and one of the beauties of that is that we get to influence policy and influence decision-making whilst also being involved in a network of other people living with the same condition. And also the European Patients Forum does a stellar job of that as well. And I think additionally, what we do need to really consider, and I mentioned this already, is how do we actually ensure that a broad range of voices from across society are actually heard? Like for NCDs like type 1 diabetes, we often think of societal issues in terms of lifestyle-based NCDs, but I think like NCDs such as type 1 are impacted, as I said, by many aspects of inequalities. And like even where I'm from in East Manchester, like you see massive inequities in health outcomes. And if we don't manage to engage people from all sections of society, then we're not going to end up with policies that actually represent the need. And there's some great examples of positive action for this. So I know in London, there's an organization called Expert Focus who work with people who've experienced homelessness and connect them to research. So and ensure that people who are taking part have adequate funding to actually take part. So not necessarily direct payments, because that can influence receipt of benefits, but things like vouchers, things just to support them to be able to participate and to kind of set that playing field. And then off the back of that, also ensuring that the voice of lived experience is seen as equal, as like a major part of a policy process. Like there's no, like, as I said already, there's no way of doing it where someone feels like disempowered. There needs to be, like, from the start to the end, patient engagement, and like actually like properly do it. So like ensure that any kind of statement that's from a patient experience panel is actually acted upon and has buy-in from decision makers as well. So not just people like involved in the lived experience network, but also like actioning it and putting it into place. And I think that brings me to my final point of really how patient and lived experience needs to be integrated into policy processes. So not just on the CSO and lobby side, but also actually in the full process. So in by institutions like the EMA and like other organizations, ensuring that patient experience is at the forefront.
Yeah. Thank you very much, and thanks to all the speakers. I think that we've heard, it is clear that if we want to improve collaboration and involvement of civil society to improve then policy making and practices, what we need is collaborating. We need to not work in silos. Again, we do need transparency. So as I mentioned before, also the fact of making sure, and Rebecca said as well, that you know how then the input of civil society is taken on board, also for the civil society, because then that's also a learning point for civil society, and it ensures transparency. Both Denis and Rebecca, you mentioned basically working holistically. We often, well, we are starting to hear more often about intersectionality. So really taking into account that every individual is unique and has unique barriers and unique facilitators that can improve or hinder their health in their lives. And that, of course, interlinks with the social determinants as well. So always taking that into account. From the slide, 2 words had come up, funding and education, and these have come up here as well. Oh, there it is. So funding, of course, we need to take into account that if people don't have an organization that backs them in terms of funding for their participation, it can be quite hard. If people have jobs, they cannot necessarily, it's hard to take time off the job. While it's easier when you work for an organization that is paying you to participate. And in terms of education, so also we talked a lot about capacity building. Very important, of course, to build the capacity of people with lived experience to be able to participate. I think it is also equally important to build the capacity of service providers, of policymakers to listen and to know how to talk together and how to create a coherent approach from involvement of patients. It is not easy, as Natasha said before, but it is possible. So thanks very much. And I think that now we are just in time for our coffee break. Thanks again to everybody. Bye-bye.